Hello, everyone. Thank you for joining Ovogene's webinar series, which are dedicated to the recent oral abstracts which were presented at ASRM in Denver. And this is a great pleasure to be connected with you this afternoon for me in the Central European time. But I know that you're joining from the different parts of the world, and I appreciate your interest to our publications and our data. And it's a great pleasure to be connected right now. Thank you, everyone, for the time you dedicated for this. My name is Dr. Uliana Dorofeyeva. I am co-founder and the Director of Clinical Operations at Ovogene, Global AI, oocyte, and sperm banking. And we are working a lot about the scientific development in the field of the oocyte donation, AI, recently about ultra-fast vitrification and sowing protocol, and other developments connected to the mitochondrial replacement therapy and the future in IVF. Today, I will present to you our results, which been published and that was the retrospective study for last 4 years between 2019 to 2023 as a single center study. But before we start, I would like to talk a little bit about the annual statistics in the field of IVF and the donor banking. The donor banking generally is experiencing rapid growth and the transformation. The global demand for the donor oocyte materials increasing, and this is due to new technologies in the field and also due to the social economic changes globally. What we may see that we recently have about 35% increase in demand of the donor oocytes in the different destinations and geographical locations all over the globe in different countries. Over 7,000 clinics are operating currently, and this number is rapidly growing. Over 600,000 IVF deliveries are happening in the world globally. Even though we started practicing IVF less than 50 years ago, we know that over 2 million kids are born, and we all know about the potential of this field in the nearest future. And over 3,500,000 cycles, these are the number of the RT treatments as a number of IVF cycles performed annually. Role of the donor oocyte banking is to provide an important solution for women with diminished ovarian reserve, poor oocyte quality, and the genetic disorders which are affecting their fertility. This oocyte banking also support same-sex couples and the single parents who are looking also for the opportunity of having their children. That gives an opportunity for couples and individuals to use eggs from the younger and often healthier individuals, healthy source, improving the chances of successful conception and the healthy pregnancies. Who are the oocyte donors? And we know that the regulations differ globally, and in some countries, oocyte donation is fully allowed. In some countries, it is not. That's why patients need to travel to different destinations. And the donors also, there are countries which have the cultural traditions to be oocyte donors. As Ovogene operates now in 6 different countries, we know a lot about differences which rely to the culture traditions, education for the oocyte donors, safety measurements, protocols, quality standards, and so on and so forth. And our aim is to control everything so well in order to satisfy the best outcome for the donor and secure and the safe protocols and the treatment for them, and the final successful outcome for our partner clinics and the individuals globally. So the oocytes donors are young and healthy individuals in their age between 21 to 30 years old. We have decided not to include donors who are over 30 years old several years ago after conducting a study about genetically certified oocytes and evaluating the percentage of genetically abnormal aneuploid oocytes coming from the cohort of the donors with the different ages. We evaluated the age of donors between 18 to 21, between 21 to 25, between 25 to 30, and over 30. And we found it, and that was already published, we just proven this additionally, that slightly higher aneuploidity rate is for the donors very young, who are between their age of 18 to 21. And also some countries, as Ovogene operates globally, they do not accept donors to be a donor until they are fully in their mature age, which is starting in some countries from 21. That's why we are not including this population of the oocyte donors. And for the donors over 30 years old, we also evaluated the fact that the aneuploidity rate goes up while woman is becoming older. Of course, this is a not advanced maternal age. We cannot call 30 years old as advanced maternal age. However, as we are struggling for the best results and the outcome of each potential oocyte which we are producing, and as a result of each and potential donor, our donors are excluded from further donations if they are over 30, with some exceptions based on their previous outcomes and previous euploidity rate, but not just the morphological selection, but mostly euploid outcome. So the age of donors ensures optimal reproductive potential. In terms of the ovarian reserve, donors are the candidates can be donors who are classified as optimal and the good responders, and the ovarian reserve is assessed by the antral follicle count and for all antimullary reserve. And we include donors into further donations if their antimullary reserve is over 3 nanogram per ml and up. And the health status, all individuals who wish to be donors, they are healthy, they are fully screened, and this ensures the optimal oocyte quality and the safety for their further process. If we are talking the role of the donor screening for oocyte banking, this is a win-win strategy for both directions. First, for the individuals who wish to be a donor, meaning they are fully screened and they are sure that they are healthy individuals, and this is the additional benefit for the candidates who wish to be donors to get this reduced screening and to be sure they are the healthy individuals. And from another hand, this is the safety and the quality assurance for the oocyte banking. There is initial examination and the consultation, including hormonal screening, infectious disease testing, psychological evaluation as the necessary part of the initial investigation, genetic testing and the counseling, a lot of consents and the paperwork and the education about the further process of the oocyte donation, and the quarantine screening to ensure there is no viral diseases on the period for the oocyte retrieval. Regarding the genetic testing for the oocyte donors, as the regulations surrounding the genetic testing for oocyte donors vary significantly worldwide, several years ago we decided to implement the rule of the extended genetic testing for all oocyte donors. So in addition to the karyotype and cystic fibrosis, which are the most commonly requested tests all over the globe, again, it's different on the different regulations and the countries. We also do Fragile X testing, SMA, phenylketonuria, hair loss, genetically related diseases, and many others. And currently, our rule is to do extended genetic panels with the minimum of 140 mutations and above. In order further to process and to guarantee the safety of the overall process, because the truth is as well that more we test the extended genetics for any individual, the higher is probability that we will find some mutations as being on the status of being a carrier of the mutation. Of course, donors who are dominant for any mutation, they will be excluded from the further donation. But if they are just carriers, we are not excluding. However, we educate the clinics and the patients in order to do the proper matching between the individual, the parent, the partner who is going to provide the sperm, and the oocyte donor. In order to do it much faster, as we implemented and more effectively, as we implemented a lot of AI tools in our daily practice routine, which gives an opportunity to optimize the workflow, the load, and improve the quality and the safety of the processes. As well, we implemented genetic matching system, which helps to our genetician to match between different panels of the extended genetic testing performed for the donor and for the partner, the compatible genes, and to help to provide the consultation further in order to understand the matched genes and the details of those genes in order to download report within several seconds. So this gives an opportunity to perform the proper matching and the safety of the overall process about the further oocyte donation. Qualification process overview. In order to understand how important is the role of the overall screening and what is the numbers of the initial consultations performed, they are about 70% more than the number of the donors which may be assessed into the further treatment and the stimulation. So let's say, seeing the numbers here, if we have 10 initial consultations per day, we would expect only 3 candidates to be eligible to continue with the screening process, and they will be confirmed as the oocyte donors who will be able to continue the process of the stimulation and the vitrifying their oocytes and being eligible for the oocyte bank. So what we include here, we include the initial parameters for the oocyte donor, personal, psychological, mental conditions, genetic background, evaluating the family history, and then the infections panel, genetics, and other investigations. And then the overall process after completing the medical and the family history, psychological evaluation, measuring the ovarian reserve, infection disease, and genetic testing. Then we start the stimulation protocol in order to perform the oocyte retrieval. We will talk further about the stimulation protocol and the safety approach for the oocyte donors. However, safety, this is the most important factor for young and healthy individuals. Further, we have oocyte aspiration procedure, collection of the blood, and performing the tests which are needed in order to assure that the materials are safe and they have no viral infections. And then the embryology work in terms to evaluate the oocyte, perform their AI selection and the grading, which we also consider as the huge benefit of the Ovogene as the AI-driven oocyte bank. And the eggs are becoming available on the online database to be selected by the clinics or the individuals. So again, the benefits of the oocyte banking. It's already proven that while we use vitrified oocytes and donor oocytes, we increase success rates because we are using healthy oocytes with the potential of the highest clinical and embryological success rates. Once we do extended genetic testing, and for most of our donors, we have proven fertility, meaning they either their parents on their own. In some countries that aligns with the regulations in the place, but for many donors, as they may be repeated donors, we control and we prove the fact that they have donated before and they have excellent performances in terms of the oocyte morphology, embryo development potential, euploidity rate, clinical outcomes, and the live birth rate. So this also brings safety and reduces the risk of the inherited conditions and increase the safety of the overall process. While we are using vitrified oocytes of the wide choices of different phenotypes and the backgrounds of the donors, there is a great choice for the recipients. Deciding about oocyte donation is not very easy always, and we know about these psychological risks or factors which are quite complicated for the patients, and they want to be as much as possible connected with their oocyte donor. If they may use non-anonymous oocyte donor and have access to the adult pictures or the childhood pictures of the donor, this is a great opportunity which proves the better connection. But some patients are not using only this tool, but also what we offer. This is AI matching system, which helps to provide even better evaluation of the phenotypical signs of the individual and match with the intended parents. So this fact gives more opportunities to be sure that the selection which was done is the best choice possible for the couple while they decided about oocyte donation. Also, what is available, these are the physical characteristics, educational backgrounds, personal history. So all these guarantees more personalized approach of the donor selection. In terms of the time efficiency, I think that every professional right now agrees that using vitrified warmed oocyte for the oocyte donation, this is the best choice possible. First, compared to the fresh donor oocytes. Talking about 10 years ago, we've been discussing a lot while using fresh donor has more benefits while using vitrified oocytes. However, right now, with the development of the vitrification and sowing process, where the survival rate is close to 100%, and this procedure is very safe and efficient, the fact that we have already guaranteed amount and the quality of the oocytes in the storage gives a preference to the fact that we may use fresh donor oocyte, and fresh cycles, they can end up differently. We may have donor who will have a delay due to the cyst, or the cycle will not start in time, or she may mix up something with the medications or forget to do the dose of the trigger shot, or something may happen during the stimulation process. And then as an endpoint, we will not have fresh oocytes, or the quality of those oocytes will not be appropriate. And this is very unfortunate process for someone who already made a decision to use the donor oocytes, however, they have not been received. That's why using vitrified warmed oocytes, this is much beneficial in terms of the time frames and also in terms of the overall efficiency in the outcomes. And it's a proven and very high success rates. In terms of the regulations about oocyte donation globally, they differ from country to country. However, they are not significantly different, and they all include good clinical practice standards and the regulations about safety, compliance, quality, and the responsible way of performing oocyte donation itself, and the treatment for the individuals who are going to receive those oocytes. So as we were talking a little bit already about wider selection, having vitrified oocytes and personalized donor matching, you may see an advantage of the free AI app from Ovogene, which helps to perform the personalized donor matching and the best choice of the donor oocytes and the donor candidate for the patient. Also, the fact that some countries, they do not regulate oocyte donation, or it's not allowed there and patients need to travel, or the fact that there is not enough donors even in some countries where the oocyte donation is possible and legal. The fact that donor materials may travel, and they travel very effectively and safe, and they can be delivered to almost any destination globally, this gives an opportunity for the patients who would not need to travel for the treatment, and they can stay in their home country, but they may get effective treatment in their home country with almost no waiting period, no waiting list, with very high success rates once the oocytes will be delivered from the oocyte bank. So this cooperation between oocyte banks and the clinics works really well for the benefit of the individual patients globally. If we are talking about optimal ovarian stimulation and selection of the proper candidate for the oocyte donor and guaranteeing the safety of the protocol, first, the oocyte donors, they need to be good responders. And the key metrics for the good responders are age, as we mentioned on the beginning, between 21 to 29 years old, which guarantees the most optimal outcome while using dose X further, anti-Muller hormone, and here the parameters should be not for our decision. We've made this decision internally for Ovogene, should be over 3 nanograms per milliliter, and the antral follicle count, which shows the number of the antral follicles on the beginning of the cycle, over 16. So those would be the indications of the optimal and good ovarian reserve. While we are talking about selection of the optimal stimulation protocols for the oocyte donors who are good and healthy responders and optimal responders, we decide here for the standardization in the approach of the ovarian stimulation, and we are using short antagonist protocol with the agonist triggering. This is the protocol which used for all our donors with daily doses of the FSH, and the trigger shot as an agonist. And 35 hours post the egg retrieval, post the trigger, we perform the egg retrieval, denudation, oocyte assessment, and oocyte vitrification. According to all guidelines and the recommendations, short antagonist protocol with agonist triggering is the stimulation protocol of choice, the first choice for the safety approach for the oocyte donation, which reduces the risks of the OHSS, which should not be seen for the treatment of the oocytes donors. And this is true that we almost do not see during last 4 to 5 years, once we moved to the short antagonist protocol, any risks of the OHSS. So I would like to present you our study, which is retrospective cohort study, and the objective was the donor oocytes from 6 consecutive ovarian stimulation cycles were developmentally competent to the blastocyst stage and resulted in clinical pregnancies following embryo transfer. The donor age was between 20 to 30 years old, and we included 96 oocyte donors. The study was performed between January 2019 and December 2023. The mean age of donors who were included in the first oocyte stimulation round was 23.2 years old and 27.8 at the 6th stimulation round. The mean age of oocyte recipients were between 33 to 34 years old. Statistical difference in the mean follicular oocyte index, number of M2 oocytes retrieved, oocyte maturation, blastocyst use rate, and clinical pregnancy rates were assessed using a student's test and the human Whitney test. Results showed that follicular oocyte index ranged between 73% to 81%, which corresponded to the second and the fifth cycle of controlled ovarian stimulation. The mean number of the oocytes retrieved was not significantly different across the 6 consecutive ovarian stimulation rounds, rising from 18 to 22 in the first 5 attempts and being 21 at the 6th attempt. Oocyte maturation and blastocyst used rate fluctuated considerably between the cycles. The lowest and the highest mean maturation rate were observed after the third and the fourth ovarian stimulation cycle, and they were 81% and 84%. Blastocysts delivered from the donor's first stimulation round cycles were used less frequently than blastocysts derived from the sixth cycle, and these were 12% of the blastocysts versus 18%. The oocyte recipients with up to 3 embryo transfer attempts had fertilization rate of 96% and blastocyst used rate of 67%, clinical pregnancy rate of 61%. Whenever oocyte recipients with 4 to 6 embryo transfer attempts has fertilization rate of 94%, blastocyst used rate 64%, and clinical pregnancy 63%. To conclude, the findings of this retrospective study suggest that donor oocytes from 6 stimulation rounds remain developmentally competent to the blastocyst stage and can be successfully clinical pregnancies followed embryo transfer. Despite the concerns regarding the potential negative impact of repeated oocytes retrieval cycles on embryological and clinical pregnancy outcomes, our results indicate comparable performance across multiple controlled ovarian stimulation rounds. So, to impact from this study, if undergoing 6 consecutive ovarian stimulation cycles in 4 years, this has no long-term health effect on the oocyte donors, and the oocyte donation program can aim to maximize the number of the oocyte retrieved during the repetitive stimulation rounds. If we are talking about how many IVF cycles is too many, this is a very frequent question asked by our patients as well by our oocyte donors. There are no universal guidelines on the maximum number of IVF cycles that one person can undergo. Regulatory bodies and the guidelines suggest that 6 is the maximum number of cycles recommended to be performed. European regulations, ASRM regulations, suggest 6 rounds for the stimulation for the oocyte donors, which we are following as well at Ovogene. And the American Society of Reproductive Medicine recommends that women under 35 years old who are not necessarily to be oocyte donors, but also patients, should attempt up to 6 cycles of IVF before moving to the alternative options. On average, and from another hand, research has shown that about 65.3% of patients, or 2/3 of patients, have successful outcome after 6 or more IVF cycles. This is especially applicable for the patients under the age of 40, meaning 6 is not a current maximum number globally, and this is not practical findings from the overall population and the generation of the patients who undergoes IVF, either they are patients or the oocyte donors. However, as the motivation for the patients may be different, and still we can add many add-ons and we can change the outcome of the stimulation rounds while developing the new tendencies and the techniques and new approaches for the IVF. It's reasonable to continue because we are evaluating the risks and the risks associated with the multiple attempts. And for example, the recent practical committee of the American Society of Reproductive Medicine has published the committee opinion about repetitive oocyte donation cycles. And here I would like to highlight the risk management, which is associated with the maximum number of cycle per oocyte donors. And the previous expert opinion, which was in 2014, has suggested a limit of 6 cycles per donor. And the current recommendation continue to support this approach. The basis for this recommendation is rooted to a concern over the potential cumulative risk occurred after a donor undergoes 6 ovarian stimulation and egg retrieval procedures. For the cancer-associated risks, the preponderance of data does not demonstrate an association between the use of ovarian stimulation agents and cancer, including invasive ovarian cancer and the breast cancer. And the summary of the committee opinion shows that the oocyte donors are exposed to the risks attendant of the ovarian stimulation, oocyte retrievals, and the anesthesia. And those risks are mainly associated with the OHSS syndrome, which is ovarian hyperstimulation syndrome, while if we are selecting the protocol, which is the SAFE protocol, antagonist short protocol with agonist triggering, the estimated risk of the OHSS is close to 0. So we almost do not see ovarian stimulation, hyperstimulation syndrome in our current practice. The risk of the serious acute complication associated with the procedures is very small. It's less than 0.5%. The preponderance of the data does not demonstrate a significant risk of future cancer, as we already mentioned. Still, this data is limited, but it's already proven to not associate the correspondence between the increased long-term risks of overall well-being on the health status with the number of the IVF attempts. And if we are having like a practical opinion from the healthcare professionals who are an IVF clinicians and doctors, we may find different publications which show more than 6 stimulation rounds, and there is one of these. Is there a limit for the number of in vitro fertilization cycle for the individual patients? And this study examined where and when conception may be achieved in multiple repeated in vitro fertilization cycles. They evaluated over 2,500 cycles in their unit, and the pregnancy rate statistically significantly decreased after the third cycle attempt, but no statistically significant decrease was observed between cycle 4 to cycle 20, meaning those patients were stimulated for 20 times. An acceptable clinical pregnancy rate per cycle of 15% was achieved between cycle 7 to cycle 20. So this is more practical data from the field. However, this may more be associated with the stimulation of the individual patients than the oocyte donors, where we also agree that the oocyte donors should be limited in number of their attempts. However, increase of those numbers of attempts from the first stimulation up to 6 stimulation does not impact and lower the potential outcomes and the results. Another important point which limits the number of the oocyte donation cycles per donor is the family limit of babies born globally. And this is very important and responsible fact which we really need to control. Some countries, they do have their own system how to control this. However, globally, we don't have one system which will be able to evaluate this. So that's why for our responsible approach, being a global oocyte bank, we implemented the AI tool, which also helped us to select a donor from the list of donors. If this is not a donor who donates initially in our bank and her oocytes have been sent somewhere, we follow to which country those oocytes have been sent and monitor the outcome. There are countries where a donor can donate only once due to the population number. Such countries, small countries like Macedonia, for example. Some countries, they allow up to 10 family limits as UK. Some average size countries as Romania would allow 5 family limits. Ireland, just 3 family limits, so on so far. So that's why we need to control, and we do this as from one stimulation round, we may create several cohorts for the oocyte, for the donor oocytes, and these cohorts may be sent to the different destinations. So our internal system shows us the limits and the opportunities if this donor has been donating already to the specific country, and if the family limit is already reached there or no, and if the donor still can donate further to that country. That's very responsible approach. This study, which I presented today, that was one of our, let's say, youngest scientific results, as it was running some time ago between 2019 to 2023. Now we are performing many, many more, and they are really interesting, involving AI tools, and they are deeper in terms of the scientific knowledge and the evaluation of the processes. We are going to present some of them further in the 32nd World Congress of the Controversies of the Obstetrics and the Gynecology in Portugal. Some other studies we will present in the Middle East Fertility Society. So, and also we will have 2 more webinars about embryological development for the AI system and the ultra-fast vitrification and sewing protocol, which were also oral abstracts and the presentations at ASRM. So stay tuned, and thank you for your interest to Ovogene. And just to conclude, I would like to say that the donor oocyte banking plays a vital role in addressing infertility and widening reproductive choices for many individuals and couples globally. And as the landscape continue to evolve in advancements in technology, regulatory frameworks, and the cultural acceptance, donor oocyte banking is poised to become even more accessible and effective on the global scale. And the cooperation between patient and the bank, and the clinic and the bank, this is the win-win opportunity for all sides. Thank you so much for your attention, and we'll be happy to see you again.